Well, yeah.
I was once at event at
Now I can hear that. See, that is what happened yesterday.
I'm hearing noise, right?
I came through late.
Is your mic off? I'm hearing noise.
touch me, and I melt into your yearning. You touch me, and I melt. You touch me, and I melt into your yearning. You touch me, and I melt. You touch me, and I melt into your yearning. You touch me, and I melt. You kiss me, and I never wanna stop. 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 You tell me that you love me, I believe it. You touch me, and I melt into your yearning. You touch me, this isn't good. You touch me, and I melt into your yearning. You touch me, and I melt into your yearning. You touch me, and I melt. You touch me, and I melt into your yearning. You touch me, and I melt. You touch me, and I
Good morning, ladies and gentlemen, participants of the conference on CSTL. This is day 2 of our conference. So we are declaring this session open, and we've got a rundown from now until 12 o'clock, where we are going to be taking different presentations. And the theme for today's session is health and social protection in the era of COVID-19. As we continue to improve the status of education in South Africa and in the SADC region, we are implementing the care and support for teaching and learning programs in our school to ensure that our schools remain safe. When COVID-19 came, we were all taken by surprise, and we were grappling as different countries in responding to COVID-19. It did have impact in our schools, especially in the education space within our schools. Therefore, the CSTL programming has become much more important as we continue to respond to providing safe and effective education post-COVID-19 era. So my first speaker today is Dr. Lombali Kumboneki, who's a program officer for HIV in the SADC. He is a passionate and experienced medical doctor and researcher with more than 15 years experience and interested in reducing mortality and morbidity of related infectious diseases. He holds a PhD in public health and an MBA, and he has co-authored and authored several research papers, and currently is working for the SADC Secretariat, as I have indicated. Dr. Kumboneki, today's topic is Eastern and Southern African Ministerial Commitment on Comprehensive Sexuality Education and Adolescent Sexual Reproductive Health between 2015 and 2020. We're looking at the evaluation findings and renewed ISA commitments towards 2030. Over to you, Dr. Kumboneki.
Thank you. Thank you very much. Good morning, everyone. Thank you for welcoming me to this important meeting. I'm not going to be long. I'm just going to take you through the findings of the evaluation of the ISA commitment, which was conducted early this year by the SADC Secretariat, the EAC, and also the UN partners who have been very supporting during this journey. So this is an important meeting for us because we're going just to brief you the finding of the commitment prior to the renewed commitment, which we expect to be signed during the next conference at the ICASA, during the next ICASA conference in Durban early next month. So without further delay, I'm going to share my screen and provide you with a summary of the finding of the ISA commitment. I hope now you can see my screen. Yeah. Can you see my screen, Chair?
Yes, we can. Thank you.
Okay. Thank you very much. So I'm going to take you through the finding of the ISA commitment. As we all know, the ISA commitment was first signed and confirmed in 2013 by 20 countries, but later on, one country joined, which was Rwanda, which makes it a commitment which was signed totally by 21 countries. And the ISA commitment signed in 2015, and in 2013. By 2015, there's been countries reaffirmed the commitment, and when the ISA commitment was signed, there were targets which were to be achieved in 2015, and other targets were supposed to be achieved in 2020. So this evaluation has been looking at both the targets and the different targets, and also how we achieve them. The ISA commitment, as I earlier mentioned, is being signed by 21 countries, and you could see on the map the countries which have been which committed themselves to reach the target that we set by the ISA commitment. In those targets that we've been talking about, in 2015, the first target was mainly to put in place a good CSC framework in the countries and making sure that we have the pre and in-service SRH and CSC training for teachers, health and social workers in place. And by the end of 2015, we agreed that we will be reducing by 50% the number of adolescents and young people who do not have access to equitable, to good youth-friendly services, as we've been calling them lately. And for concerning the targets that we set in 2020, we have said that the most important point was also not only to consolidate the hard-won gain in the fight against HIV, especially in terms of new infections. So it was to eliminate new infection among adolescents, but also to increase the comprehensive knowledge of adolescents. Remember, when the ISA commitment was signed in 2013, the target, the HIV comprehensive knowledge among youth in the region was estimated at around 36%. So the target was to make sure that we reach 95%. The next target was concerning early and unintended pregnancy. We agreed that we would reduce early and unintended pregnancy by 75% by 2020, eliminate gender-based violence, and also increase the number of schools and teacher training institutions which are providing comprehensive sexual education. So the evaluation, which, as I mentioned earlier, was conducted by the SADC Secretary, the EAC, and also the UN, who has looked at all those achievements, and this was made through a mixed approach. The mixed approach, we have first proceeded by mapping and reviewing, and this study actually, which helped us to map the different stakeholders and also proceed to a thorough document review. We have done some survey online and also key informant interview, which helped us to, which was the basis of the triangulation analysis that which was conducted, and also helped also in formulating the recommendation. So what are the findings of the ISA commitment? On the finding, I'm going to see which approach did we use actually. When you look at in terms of relevance and coherence, the ISA commitment globally has got has influenced the development of policies at national level, at regional level. Like, for example, when you're looking at country levels, we've got that political will which is visible. Hence, you've seen that. So several programs in terms of addressing youth issues. There are also policies specifically addressing youth issues in member states, but we also have the youth-friendly services which have been put in place in countries. So just to show that the influence that the IFSA commitment has been having. But some challenges as we have still been having noted challenges, especially in terms of updating or even aligning our national laws to the commitment. That has not been, we did not live up to the expectation that we had at the beginning of the ISA commitment. We are also talking about the implementation of law for youth and adolescents, which did not also follow what we expected at the beginning of the ISA commitment. On the second part, in terms of influence of the ISA commitment at the regional level, we have seen that at regional level there's been that robust engagement, especially at the level of the regs such as SADC and EAC, where you have especially dedicated officers who are following days and nights and monitoring the ISA commitment implementation. And also in terms of contributing to the needs of adolescents, we have seen, as I mentioned earlier, that the acceleration of legal and policy development and strengthening the adolescent SRHR. And also we have seen also the UN organization being in the forefront, supporting different initiatives and also implementing directly initiative at member states. So those have been the positive side of the ISA commitment and the influence that it had in the region and also on different countries in our region. Now, on the second evaluation point, we have looked at the effectiveness of the ISA commitment, which talks to the CSC, the development and the implementation of the CSC curriculum, the implementation of pre and in-service CSC and SRH training, accessibility to youth-friendly services, HIV services. This is also one of the most important points here, is the linkage between education and health, elimination of HIV infection, reduction of early unintended pregnancy, improvement also of knowledge, HIV knowledge, comprehensive knowledge about HIV, and elimination of gender-based violence and also child marriage. So those are the points that which we've been looking at while assessing the countries, and this is. Those findings have been presented in different forums. We have presented them there's been a regional consultation with member state of the SADC and the EAC. There's been also presentation to the ministers of education at SADC level. This happens also to the ministers of health at SADC and EAC. There's been also a regional dashboard which has been put, which can facilitate with this through this presentation. We are also going to share the link with you to see how the different indicators that we are reporting on have been appear on the dashboard, and what are the progress that we have done. So this is just a snapshot on how the dashboard will look, and also to give you an idea on the progress and also on the implementation of the ISA commitment. So now I'm going to share with you a few more data that we have seen in terms of elimination of all new infections. As you've seen, we all know that in the region, the ESC and SADC, we have not reached the target of reducing infection by 75% through the UNAIDS commitment. But also, when you look at it generally in the general population, we are at around 37% reduction for both SADC and ESC. However, when it comes to adolescents, it's lower. It stands around 29 to 30%, which shows that we did not achieve the target that we've made. There's been some encouraging news when you look at some countries where you've seen some reduction beyond 40%, but this is not the case. As you can see on the table on the blue side, you look at the new infection in 2013 as compared to 2019 for female. You could see that the decline is not that much. It's not steep. So, which means we have not lived up to our expectation. You get the case like South Africa has got as much too much progress. When you look at in 2013, it's 98,000 adolescent girls and young women, and while now in 2019 it reached 55,000, which gives you almost a reduction of above 40%. But this has been one of the few cases. But there are countries which has been stagnant. When you look at, for example, Angola for the male, it has been stuck between 2013 and 2019. There's not been progress. So these are the key findings that we are talking about. We are looking at also to see what can we do now to improve, and the implementation also ensure that we reach the target and we end HIV by 2030 as we have committed. Concerning the increase in the 90% in terms of knowledge on average, you will see that there's not been much improvement. We in 2013 it was estimated at 36%, while actually during the last evaluation in 2019 it was estimated at 40%, which means when we look at we assess it globally, regionally, it gives us only an improvement of 4%, which means we are far much below the expected targets that we have set for ourselves. So it's also important to look at and see what needs to be done to improve HIV knowledge among adolescents, which will help them also to prevent it effectively. We are looking at early and unintended pregnancy. There has been mixed result here. When you look at the map in front of you, you will see that some countries have declined, which are highlighted in green, but while we have at least 4 countries in which the rate of early unintended pregnancy has gone up. It shows also again that we did not reach our target. However, also the data here are really lacking. There are countries where it's difficult to collect those data. Hence, also one of the recommendations of this report is mainly to strengthen the M&E side part of it to ensure that we collect the right information, and when we report to our principals, we come with real facts and information which will guide in decision making. Concerning the child marriage, we've also have a mixed actually the result. It's a mixed result actually. When you see, you have some countries which have reduced the child marriage, but while in other countries we have increased it. And even if we have reduced, we targeted to reduce at least by 75%. But when you look at the reduction, it stands around 3 to 5%, and in most cases it's between 1 to 2%, which means there's not been much progress in that. And also we have some countries which have been stagnant in that regard. So it's also important not only to develop and adopt the laws, but also to implement them. Because when you look at all the countries now, as we mentioned before, those laws have been adopted. We have adopted the laws against the child marriage, but we are not implementing them. So it's very important for us now to implement them and move forward and see. So we are looking at also remember that one of the targets was CSC. CSC, in terms of countries which are having like a percentage of school providing life skill based HIV and sexual education, you could see that there has been most countries. First, in terms of CSCs have been developed in almost all the countries. Like the curriculum is present, and also we could see that this is one of the area where most countries have done very well. Or you have several countries, almost 8 countries having 100%, and others are around 80 to 75%. But though we still have some countries which are lagging behind, but at least here we could see that there's been much progress in terms of providing life skills-based HIV and sexuality education in those countries. When this is the map just which is showing you that the availability of the CSE framework for out-of-school youth, and as you can see, we only have 2 countries which we could not collect data information, but out of the 3 countries, but out of the 21 countries, we've got 18 countries having a CSC framework in place, which helps also in addressing the issues of HIV and sexual reproductive health of adolescents, for youth actually. And we are also looking at the availability of policies related to school-related gender-based violence. When you look at it, you see that we've got policies which are in place in most countries, but while we have 5 countries which do not have those policies. And in this regards, when you look at also the result, you see that at some point, as I said, it's important for us to strengthen the M&E part of it, because what is happening here, you'll see that we are sometimes, when you do the evaluation, we are limiting ourselves to assess the existence of policy, while it's important for us also to go down and look at the implementation. So those are some of the limitations of the report, which could not go further in analysis due to the lack of data, the lack of tracking of they could not track those data actually. We are looking also at countries that provide pre and in-service training programs on the delivery of adolescent and youth-friendly health services. Remember, one of the targets was to have youth-friendly services. At least for this one, all countries have got them. Their training have been provided, and youth services have been in place. Though it's not perfect, it's not at the same level everywhere, but we have started somewhere. There's a good starting point, which shows that the youth-friendly services are effective, they are existing, and we need now to improve them during the last 10 years if we are to achieve the 2030 target and also the ISA commitment. Now, looking at the efficiency, as I said, the gaps reported in the lack and strengthening responsiveness of the M&E, it's very important. It speaks for itself. Some of the target could not be reported accordingly because we did not have the right information. We could not find the right information at country level. So it's important that we make sure we improve the M&E system, the M&E collection, the data collection to inform our decisions and also to guide our principals when they take decisions. So these are one of this is the most important gap that we have noted in the evaluation. In terms of regional coordination, there's been, as I said, there's been regional coordination. There's been at regional level, at SADC level, at EAC, there's been regional coordination. However, in terms of what has been reported when we are looking at it, it's mainly in terms of inadequate human resources, even financial support to go further into supporting the implementation of the ISA commitment, and also monitoring that implementation. So it's very important that when we are looking at the next 10 years and we want to achieve a good result, we need to strengthen those areas. In sustainability, as we said, the ISA commitment, there are mixed results across the region, especially that we are looking at the government level of ownership. In some countries, you could see that the system is embedded within the government structures, because this needs a multi-sectoral approach. It's very important. And we are looking also the tendencies across the region. The CSE remains implemented at a small scale through some project of CSO, so it's not really embedded in the system. And then the most and important gap is about insufficient data collection, which remains the most important gap in our implementation. So it's very important. We insist on that. We need to strengthen our monitoring and evaluation, and those gaps have been highlighted by the COVID-19 pandemic. As you've seen, the COVID has affected our life in all the ways. So basically, this has been also been highlighted during that period. There's a range of strategies that we need to put in place to improve multi-sector and multi-stakeholder collaborations. This is very important. Why do we say that? The ISA commitment at the beginning has been also has been signed actually by our ministers of health and the ministers of education. But what we have noted also during the process of implementing the ISA commitment, you have seen also the ministers responsible for youth have come forth to make sure that this commitment has been implemented. Hence, we need also to leverage on that experience to ensure that we have a broader, a holistic approach in implementing the ISA commitment. And this also helps also in fostering exchange on policy and structural changes and lesson interventions and discussion on scalability is still lacking. So it's very important for us to look at those issues and sustainability. So now, after this evaluation, what are the key recommendations? The key recommendation is to make sure that we use and test innovation with strong documentation and best practices. Documentation and best practices, as we said, it will depend on our M&E evaluation. We need further disaggregation on data. Further disaggregation will help us to know exactly, to scrutinize, to microscopically analyze the factors which are driving the HIV epidemic among youth, and also which can help us to improve the SRHR services for those youth. And we need to conduct a systematic review of the implementation modalities of the CSE. In terms of relevance of coherence, we are talking about a robust engagement of CSO. We had to support the REC, and also we need to ensure that the ISA commitment now it's a more holistic approach at a higher political level for the engagement, and ensure that we have the highest office to be involved in the ISA commitment. In terms of efficiency, what you're saying, the ISA commitment, we need to strengthen coordination, accountability. We need to improve the quality of teaching and learning. We need to improve to increase domestic resources mobilization to support the ISA commitment, and also to ensure that linkage between the school and the health system is strong, and it's functioning well at country level. We need to look at those to facilitate to facilitate sustainability. We need to develop and report on composite youth indicator for the well-being, and also fast track the review, harmonization, and implementation of law of the law which are supporting youth health in our countries. And as I rightly mentioned at the beginning, we have the new commitment which is going to be signed. I'm just going to give the proposed new commitment because it has not been signed yet. Countries are still discussing, but however, there are some few highlights which are important to mention. As you look at the new commitment, education and CSE remain the key in reducing HIV. However, we have new factors which are coming, like the gender-based violence, which is now more prominent, and we need more here to address it more. And it's also well addressed in the new commitment. We are looking at the impacts of challenges such as COVID. We are looking at the issues of prioritizing a multi-sectoral approach, which will help us in invest in health education, and also to improve the skills of our youth. And there are issues of inequalities in terms of education and the way we treat our girls when they get pregnant, the chances we are giving them after this pregnancy. It's very important that we address those issues. There's issues of inclusion of adolescent sexual and reproductive health in the National Universal Health Coverage packages. So it's very important. We need also to strengthen communities and also increase the engagement, to enhance the engagement between the parents, the community, and the youth. So those are the few key highlights which will come in the new commitment, which will help us also to strengthen the implementation beside the M&E component, which is key and which is the backbone in the implementation of the next ISA commitment. With that, I'll say thank you. Over to you, Chair. I'll pause here, maybe expecting some question from your side. Thank you.
Thank you very much, Dr. Kumboneki. Colleagues, ladies and gentlemen participating in the conference, you may put up your questions on the chat box, as well as you can comment also on the chat button of the chat box. As we continue with our program, just to highlight, ladies and gentlemen, that we will be taking live questions at the end of the session. So if Dr. Kumboneki, you can hang around until we get to the end of the morning session. By 10 o'clock, we are hoping to be taking questions. Just to indicate, ladies and gentlemen, that today's session is taking against a backdrop of the country launching the 16 days of activism for non-violence against women and children. So we will be observing a couple of activities in the country for the next 16 days, where we'll be also focusing on adolescent girls and young women and the plight of HIV infections, increased rates of unintended pregnancy, and their experience of sexual exploitation in the country. Let me take my next speaker, Ms. Yvonne Tagurei, who is a research and development specialist for MIET Africa. She is a legal researcher and a social policy specialist with more than 14 years of experience in human rights. She has sound knowledge and international and regional human rights standards. She's participating in different fora in the region, looking at how we support the children's rights, as well as ensuring that the social economic rights of children and youth is looked after. May I hand over to you, Yvonne, for your presentation today, talking about the impact of COVID-19 on adolescents and young people in the SADC region, focusing on education and health. Over to you, Yvonne.
Thank you, Madam Chair. Good morning. I'd like to recognize the presence of the SADC Secretariat, Dr. Lamboli Kumboneki, and the Honorable Minister and Deputy Minister of the Ministry of Education, and also representatives from the Department of Education, UN agencies, civil society organizations, distinguished guests. My name is Yvonne Tagurei, and I will be presenting on the impact of COVID-19 on adolescents and young people. With your indulgence, colleagues, I will share my presentation. Right. Can you see the slides?
Yes, we can.
Thank you. All right, so the impact of COVID-19 on adolescents and young people was research that was conducted by MIT Africa and the Human Sciences Resources Council. And the objectives of the research study was to establish evidence on how the COVID-19 pandemic is affecting the lives of young people in the SADC region, really focusing on the most marginalized children. And we wanted to also conduct a critical analysis of the effects of COVID-19, particularly looking at access to SRHR information and services and products in light of the school closures. The study also sought out to map out and analyze children and young people's perspectives and views about how the COVID-19 pandemic was affecting their access to education, including their physical and mental health. And we also wanted to assess how COVID-19 is changing the way schools and their broader support networks are operating, both in the delivery of teaching and learning and care and support. Over and above these objectives, the study also wanted to identify some key priority areas for SADC states and to really recommend ways of improving and accelerating the teaching and learning during the lockdowns. The study followed a qualitative and quantitative method where we sought to extrapolate information from respondents from government ministries, from civil society organizations, as well as UN agencies. So a total of 389 respondents responded to either an online survey or key informant interviews or FGDs. So we had 82 responses from an online survey that was targeting adolescents and young people from 6 SADC member states. We had 31 key informant interviews with the SADC Secretariat, UN agencies consisting of UNESCO, UNICEF and UNFPA, as well as FGDs with the Ministries of Education, Health and Child-focused ministries. The study was conducted in Lesotho, Malawi, Madagascar, Zambia, and Zimbabwe. And we were really focusing on countries where MIT Africa has presence, but also where HSRC has been programming on the CSTL and also the Future Life Now program. So in terms of the impact of COVID-19 on access to education, I'm happy that yesterday the presentations really set the tone, and really what we are seeing is that South Africa is no different from other countries in the region in terms of the impact of COVID-19 on access to education. So the weeks of school closures have definitely impacted education outcomes, especially amongst the most disadvantaged, living in remote areas, those living with disabilities, and already, as mentioned, in our region, the education sector, although gains had been made, we were still far off behind in terms of teacher-student ratio, in terms of school attendance, and in terms of maintaining young people in schools. So the projected school dropouts could wipe out gains made in reducing out-of-school youth by 25% since 2012. So we are losing about 10-year gains that we had already made in terms of access to education. And over and above access to education, COVID-19 has also disrupted the broad support services available through schools. As mentioned yesterday, issues around deworming, nutrition, psychosocial support, and SRHR education. 92% of young respondents also said that their access to general health care, particularly access to sexual reproductive health supports and services, as well as comprehensive sexuality education, had been deprioritized. And we are going to be seeing in the next slides that this also had an impact, and it has a correlation on the rise in teenage pregnancies. So there are current regional estimates that the school closures impacted 127 million learners in Eastern Southern Africa, and almost all SADC member states closed schools for a protracted period because of COVID-19. So we did a first wave analysis, and on average, we confirm, as well as presented yesterday, that young people in the SADC region really lost an average of 100 to 120 days of learning instructions. And the most closures in the first wave was Angola, followed by Comoros, Lesotho, Eswatini, and Mozambique. But during the second and third waves, Zimbabwe, Malawi, and Zambia also did record longer than 100 days of school instruction lost. We also wanted to look into how SADC member states were able to really respond fast, and SADC member states did really respond at a fast pace to ensure that education continuity during the onset of COVID-19 continued. So for the pre-primary education, we saw that radio programs and for pre-primary and primary radio programs were the most widely used forum for education delivery. And as we move from lower secondary to upper secondary, paper-based learning and online learning seem to be working. So governments chose really a diverse of policy responses and teaching and learning approaches. And additionally, many learners in SADC region, especially the youngest and the minority groups, however, were not fluent in the language of instruction, which is usually English. And this was picked up in Lesotho, Madagascar, Zimbabwe, and Zambia. So although young people did say that they were accessing learning during COVID-19 through a myriad of teaching approaches, it was really clear that they were not adequately learning, or the retention of information was not as effective as face-to-face learning. So not all students were able to access education consistently. There were competing home priorities, as well as limited home supervision, and as well as personal challenges with self-directed learning. Despite significant internet coverage growth in Africa, Southern Africa still faces major challenges on improving ICT coverage. And we saw that the digital challenges were confirmed by young people in Zimbabwe, Lesotho, and Malawi, with young people in Zimbabwe saying that for them to actually be able to have a consistent access to online lessons, they need at least $15 to purchase data. And not all young people had access to such access to funds to purchase data. So young people also said they really depended on adults' mobile phones to access notes. And we are seeing that increased digitalization of schooling is definitely likely to widen inequalities between boys and girls, particularly for girls who live in economic poor backgrounds. So the rise in teenage pregnancies is definitely a looming threat to education in the SADC region. At least 3 out of 4 young people knew someone who was pregnant, a young peer who had been pregnant. And it was an estimated 1 million girls across sub-Saharan Africa may be blocked from returning to school due to also restrictive re-entry policies in countries. And when we asked the young adults, the drivers of teenage pregnancies, some said it was issues around no access to SRH support and services, increased sexual violence, and also harmful practices and family decisions to marry off girls due to the risk of not having any economic situations to support the family. So 80% of young people needed critical SRHR services. And in their own opinion, the unmet SRH needs either in the school environment or health facilities were key drivers of increased cases of teenage pregnancies, particularly in Malawi, Lesotho, and Zimbabwe. So this is just a small, really a small reflection from a young person from Malawi we interviewed. And he was really unsure whether he would sit for his national examination due to the disruptions. In terms of access to healthcare, universal health coverage continued. Member states in SADC region did continue to try and prioritize universal health coverage. However, as we know, the mainstream subjects were prioritized during the online lessons, and comprehensive sexuality education was deprioritized during online classes. 74 learners confirmed that they purchased condoms in supermarkets or pharmacies while accessing SRH information either was online, and they did confirm that sometimes the information they accessed online was either inappropriate or did not serve their needs to adequately support them in making healthy decisions. 58% female and 42 male learners cited fear of catching COVID-19 virus in clinics or receiving poor and judgmental treatment from untrained healthcare workers. So we found that in countries such as Malawi, Zambia, and Zimbabwe, where schools are linked to healthcare facilities, where they're youth-friendly spaces, the healthcare workers that had been prioritized for supporting young people then had to move to COVID-19 response. So there were no trained healthcare officials to support young people to support, get the necessary SRHR supports and services. So schools definitely are spaces of care and support for learners. And 72 young respondents said that without going to school, they were lacking the necessary comprehensive sexuality education. And they were also saying that they were losing out on nutrition and school feeding programs. So young people said that when they were accessing SRH services, there were prohibitive costs of accessing SRHR, and also judgmental attitudes from healthcare workers were also affecting them in terms of accessing adequate SRHR services. Yesterday, we also heard that COVID-19 also led to high incidences of gender-based violence, and this was confirmed by young people, where they also dubbed the increase in intimate partner violence and other harmful practices as the second pandemic. And we also noted that there was a high increase in the number of calls that were being received by child lines in Zimbabwe, Zambia, and Malawi. And prior to COVID-19, 35% of young women globally had experienced either physical or sexual intimate partner violence, but due to the lockdown measures, these were projected to increase by 15%. And we also noted that from the young people, they said that also reaching out to law enforcement and judicial mechanisms was a challenge because courts and victim-friendly units were usually closed and were deprioritized. And in addition to intimate partner violence, most young respondents, 65% of them reported that child marriages in their communities had increased since in their communities. And with young people also saying that there was an increase in cyberbullying and online sexual exploitation, particularly in Madagascar, Lesotho, Malawi, Zimbabwe, and Zambia. We also noted that young people were increasingly becoming worried, and COVID-19 has undeniably affected adolescents and young people's mental health and well-being. And the restrictions on freedom of mobility limited their physical contact with their peers. And sometimes young people were locked down with unsupportive or abusive family members. And this really negatively impacted the health and well-being of young people. So the research also showed that the longer weeks that young people stayed indoors, locked down, the more increased effects they had on their stress levels. And we also noted that even as they experienced stress, they couldn't access their teachers who usually provide psychosocial support within the school settings. The report also looked into youth participation in decision making, and it was really glaringly clear that young people were not consulted in the formulation of COVID-19 strategies and programs. And adult respondents also did confirm that they felt that young people were not included in decision-making processes. So young people are asking leaders to be genuine and to involve them systematically and meaningfully, both in national development processes, but also in humanitarian responses such as COVID-19. So what we're also looking in terms of a social protection perspective is that our governments in Southern Africa have made commendable progress in ratifying key international and regional instruments and standards. We're also making efforts across the SADC region to meet the Abuja and Dakar Declaration, as well as the global Lynchian agreements on education. However, 84% of the adult respondents were of the opinion that SADC member states were ill prepared to address the impact of COVID-19. And a lot of financial investments in primary and universal healthcare could not cushion our healthcare and education system. And our COVID-19 pandemic has definitely shown us that our countries need to do better in terms of financial investments in health, education, and social protection to better equip us to respond to crises such as COVID-19. So the fiscal position of SADC member states will be affected with fiscal deficits forecasted to widen from 5% of the GDP in 2020 compared to a previous estimate of 3%. And this is something that we still see in most countries around the economic decline due to COVID-19. So who are the young people who are mostly affected, who have an added disadvantage during crises such as COVID-19? We realize that young people with limited or no access to internet, young people who are migrants or those who are on the move, married girls or those who are at risk of getting married, the young people living in unsafe rural remote areas, and also the young people living with disabilities. So we were able to really capture the voices of young people. And I'm going to just show a 2-minute video before I close on a young person who wanted to just give us a reflection of how COVID-19 has affected them. Thank you. So in conclusion, distinguished guests, ladies and gentlemen, is that how SADC member states respond to pandemics is dependent on how resilient their health and education systems are. And beyond the classrooms, schools continue to offer spaces of support, providing young people with nutritional meals, immunization, and psychosocial support services for their well-being and development. We do have a call to action for the SADC Secretariat, SADC member states, UN agencies, and I would really encourage us to find out more information about the study on the MIT Africa's website. And we will be conducting an update on how the COVID-19 pandemic has now evolved since the last study, where we are now focusing on looking into SADC member states' response strategies and also how the immunization rollout is going on. Thank you so much, Madam Chair, and it's a sincere pleasure to have presented this study. I submit.
Thank you very much, Yvonne, for that great presentation, looking at the impact of COVID-19 on CSE education and access to SRH education, as well as services. Colleagues, as I've indicated, we can chat on the chat box or post our questions on the question tab on our website. I'm quickly going to move to the last presentation of this morning session to Colleen Wagner, who's the Adolescent Girls and Young Women's Program Manager at NACOSA. NACOSA is a global fund PR, and Colleen is a nurse by profession. She has over 20 years in her career. She has worked in different nursing fields within the occupational health, pediatric health, as well as prevention and in clinical trials. She holds a master's degree in nursing, and she is currently working on the promotion of disease prevention programs aimed at adolescent health to safety transition into the second decade of their life. Colleen is going to be giving us a topic today, looking at how do we reach pregnant learners during COVID-19 lockdown. Over to you, Colleen.
Thank you, C, and good morning, everybody. I hope you can hear me fine. I'm going to share my screen. There we go. Please confirm if you can see the screen.
Yes, we can.
Do you see the screen that says NACOSA? This one, the one that says My Journey. Do you see the screen?
Yes, we can.
Says... Okay.
Yes, we can.
So
Thanks,
much.
Colleen. Sorry.
Okay. So good morning, everybody. My name is Colleen Wagner. I'm the AGYW Program Manager for the My Journey program, working at NACOSA. So I'm excited to be here and speak about the topic learner pregnancy and how we've reached them. So our program, just an overview of the sub-districts that we work in. We work in Rustenburg, we work in Tshwane, and we work in Klipfontein. The NACOSA program is working in 12 sub-districts across the country, and we've started on the 1st of April 2019 until the 31st of March 2021. That's just a little background of where we are. And so I'm going to speak about the NACOSA sites. We've got 2 other PRs, absent Beyond Zero, working in the rest of the country. Just a little bit about our program. So adolescent girls and young women enter the grant for age 15 to 24, various entry points. We do what's called a risk assessment, offer HIV testing, offer condoms, we do a service plan, and then we link them to either structural, behavioral, or biomedical services based on their need. And this has to do with the NSP, so it's linked to the NSP. So then just a little bit about the care package for pregnant learners. So number 1, we identify a pregnant learner during a risk assessment. And then we refer her to antenatal clinic or antenatal care, where she will get registered if she is pregnant. If a participant prefers not to go ahead with the pregnancy, she could then have a TOP that we refer to the hospital for that. And then we also refer to the social worker for psychosocial support, counseling based on her risk or based on her need. And then post the birth, she's referred to social services DSD for the childcare grant. We also offer via our social workers, we do home visits. So we issue ECD vouchers, and this we issue once every 3 months. We issue 350 Rand ECD vouchers, and this is post-natal living support. And then we also facilitate with return to school programs. And then we also refer to a teen parenting program post the birth. So that is sort of our care package if we have learner pregnancy. So now just a quick look at the data. And like I say, it's 1st April 2019 to 31 March, to the 30th of September 2021. So we will see in the 12 sub-districts, this is the younger adolescent. So this is our in-school participant, younger adolescent for that period. And we can see for the 15 to 19-year-olds, how many reported ever being pregnant. So we see a total of 13,781 on the Adolescent Girls and Young Women Global Fund Program. All right, so we see 13,781, and we also see the younger than 15, we have 93 younger than 15 reporting pregnancy. Ever being pregnant, age 20 to 24-year-olds, this is our older adolescent. Obviously, we have fewer older adolescents in school, and we see the number, the total number in our 12 sub-districts at 10,191 for the same period. Then presently, so we've adapted our M&E tool, we adapted our risk assessment tool. So we ask the girls now in this program, are you currently pregnant? So in school and currently pregnant. And we see we have 48 in the Nakosa sub-districts, 48 presently in school in Klipfontein schools, 66 in our Tshwane Region 1 schools, and 99 in our schools in Rustenburg. And this has only been August to September this year. And so now just a little bit about COVID and how we've reached our participants in this time. So just some implementation challenges, just to list a few. We know that there are many, but tailored support is not always available. So the risk of dropping out of school when you are pregnant, that is increased. So because you don't have support. Gender-based violence and femicide, we know, is a huge challenge. And this obviously is a challenge for our participants or our learners. And so the numbers are even higher as a result of that. And then despite national policy, some schools still ask learners to stay home for 1 year following the birth, or they refuse learners even to return. Some educators are anxious that pregnant learners are attending school, either for their own reason. We've heard anecdotally that some educators say things like, I am not a midwife. And so also that due to the risk of contracting COVID in that time, learners were asked to stay home during COVID. So this meant they were missing additional contact time in school. And then also we have insufficient data available to understand to what extent did learners have access to emergency contraception or then TOP services during COVID. And then what is the circumstances around the pregnancy, like I was saying earlier on about GBV, especially if we're looking at our younger adolescents, and especially if we're looking at our adolescents under age 15. Like I say, we had 93 report under age 15 for ever having pregnant. So how did we track them? Number one, our NGO partners that we work with in our sub-districts, our NGO partners identify learners via the risk assessment conversation. Then the information is reported monthly to the school principal. The school principal signs off on the report. Then we also report the data to the DBE district office. And then as the principal recipient, Nakosa will get the data, of which we share it with DBE via the technical support unit that works on this Global Fund grant. And then we also have the SRs, the NGO partners we've got a pregnant learner tracker. And so when a learner is identified as being pregnant, they will then track her name, her age, her grade, her school, her EDD, which services she's received, if she's received a home visit, if she's gone for the childcare grant, etc., etc. So just to manage the care package as well. And then just what did we do differently? So the national lockdown allowed pregnant learners to stay home. NGO partners were liaising with educators, bringing the schoolwork to the learners. So they were offering that service. And then they supported and encouraged COVID symptomatic learners to go get tested. We also offered testing services via our biomedical SRs. There was also virtual contact maintained via WhatsApp or telephonically. And then the home visits were conducted when it was safe to do so, because to obviously give the ECD vouchers, to do the counseling and the psychosocial support, which was critical. Lots of participants struggled with mental health challenges and just everything related to COVID. And then, like I said, we also gave ECD vouchers, we gave food vouchers where it was necessary. And then we also updated our M&E risk assessment tool so that we're now capturing and tracking more accurate data and more granular data as well. And then the last thing we did, we've got something called an influencer program. So through our influencer program, we were also doing peer support via social media. So this is just one slide of our influencer program. It's peers, so it's really peer-to-peer, reaching out to each other and supporting each other. And then we also issued journals to all our participants on this program. And in our journals, we've got a really lovely page on pregnancy, some of the signs of pregnancy, where you can get help, what to do, how to manage. So just the very practical side to further support learners. This is a private journal. You take it home and then you read it in your own time. And there's the BWise, it links back to the Department of Health's BWise app, and so that they can get further support if they don't want to do it via the NGO partners. And so just in conclusion, so I said teamwork is dream work, but so we obviously needed a team to pull this off, or not a team to support the participants. So you need field staff, you need M&E staff, you need stakeholders to refer to, and then more support is needed to pregnant learners. Ongoing psychosocial support is needed as learners. You need the social workers support them to negotiate conversations with caregivers, with parents, with just a lot of care, and then academic support so that they continue with schoolwork and that the learner comes right back into education, keeping her in school. And then just the last point, we obviously need support to attain programmatic outcomes of healthy, educated, safe and strong participants or learners, and that we need to do much more in this field. I think this area of learner pregnancy is still not adequately addressed, and so we just need a whole lot more to be able to reach those outcomes. Thank you so much. Thank you for listening.
Thank you very much, Colleen, for that presentation. Colleagues and conference participants, the work that Colleen is presenting on comes at the backdrop of the Department of Basic Education just recently received approval from Cabinet on the Learner Pregnancy Prevention and Management Policy. This is the policy that is going to guide our schools, our educators, our school governing bodies, and our parents, including implementing partners like Colleen's organization, on how do we respond and continue to support our learners, first and foremost, to prevent pregnancy through the Integrated School Health Program that combines the Department of Health, Department of Social Development, and Department of Basic Education and its implementing partners, but also when our learners do fall pregnant, how do we continue to manage and support them to ensure that they continue staying in our schools and we continue to prevent the high dropout rates of our learners in our schools, with COVID-19 exacerbating most of the challenges that we are experiencing. So my fellow conference participants, just before I release you for tea, as I've indicated, you will continue posting your questions in the question tab on our screens, and also the chats we are noting. the comments, the words of encouragement, and some of the suggestions that our participants are giving us as we continue to implement the CSTL program, the ISA commitments, as well as the interventions that we are implementing. I'm just going to request you, just before I release you for tea, I've got a test for you to check if you are listening to our presentations. I've got a poll. So we are going to take a poll just now. If you go to the polls tab in your screen, and then we can be able to start with the polls. We have a question in response to COVID-19. Which CSTL pillar do you believe will have the greatest impact on recovery efforts and provide the necessary support to the system to minimize learning losses? We've got votes, health education and promotion, nutrition support, co-curricular support, social inclusion, school safety, infrastructure, water and sanitation, curriculum support, learning and teaching material, welfare support, and psychosocial support. So from these pillars that are listed, if colleagues, you can vote to say which of these pillars is critical and great, would have great impact in the efforts that we have in improving our CSTL programs post-COVID-19 response in the different countries in the SADC region. I've got two questions that I think we can take before we break for tea, sorry. One question is to all the presenters. So if my presenters can show by show of hands, if they would like to take the question. If there was one aspect or focus area that would suggest for 2022, what would that be? And the second question, I never really thought about the interface of national policy that encourages continuation of learning as long as possible for pregnant learners vis-a-vis having to ask them to stay at home during COVID-19. How are we to balance this? I think, Colin, I would ask you to take that question. And then the first question is to all presenters, also looking at, on your opinion, based on your educated opinion, what is the focus area that you would suggest that would take us towards 2022 in responding or in strengthening our education post-COVID-19? Dr. Kumboneki, can I take you for your comment?
Oh, okay. Thank you. Thank you very much. Thank you very much, Chair. My line is not clear. I didn't get well the first part of the question. Can you repeat, especially on the point?
So the first question is, if there was one aspect or focus area that you would suggest that will take us to 2022, what will that be?
Mm-hmm. Okay.
Within the framework of CSTL, a post-COVID-19 response.
Oh, okay. No, thank you. Thank you very much, Madam Chair. So I believe now today that COVID first has highlighted so many gaps which are existing in our systems, especially the need for us to look at the CSC provision, out of school CSC provision, and also the need for us to ensure that learning never stops. Learning never stops in terms of, we are talking here about issues of connectivities, we are talking here about issues especially for underserved or for poor community, remote community. So one of the key aspects that we would like to focus, that to make sure, we have to make sure that now we improve those issues of connectivity. We have to make sure that also we strengthen CSC, especially the out of school, because we are not sure that we will still be having our kids at school, our youth at school. We have to to give provision for strategies which are going to help us to reach children even when they're out of school. So this speaks also to the issue of community engagement, which needs to be robust. We need to speak also the issue of parents' involvement into the process of CSC. We need to improve that dialogue. Hence, you've seen also one of the main recommendations has been the improvement of dialogue at community level, at family level, and also to ensure those connectivity issues. So those are the main key factor, the main key point like that framework like that I think we need to emphasize for the next year and urgently. Thank you. Over to you, Madam Chair.
Thank you very much, Dr. Kumboneki. Yvonne, any insight from your side?
Thank you so much, Madam Chair. Certainly, I agree with Dr. Kumboneki that for efforts to build back better, we need to definitely ensure that learning never stops. And there is already research that is indicating that there isn't a direct correlation between lockdowns and school closures in terms of how young students can infect teachers. So I think what we need to ensure is that even as the different waves are coming, we invest a lot in safety and care. Greater investments need to be done in WASH, ensuring that our schools have the adequate infrastructure to ensure that we do not close schools unnecessarily, and investments again in catch-up programs. Back to school campaigns are definitely needed in the region. And as mentioned, greater investments as well in comprehensive sexuality education and SRHR support services. They are life-saving. Studies are showing that if we do not support and give a framework for care and support within our schools, we definitely lose a generation. And again, the most marginalized, Madam Chair, I think for next 2022, our member states need to really make targeted efforts to ensure that girls are not left off far west off, and those with disabilities and those living in remote areas are not left behind as we try to accelerate SADC member states meeting the SDG goals. Thank you, Chair.
Thank you very much, Yvonne. Colleen, any comments from your side? Looking at what are the crucial activities that we need to undertake that are important to take us forward in 2022 as we respond to COVID-19 and ensure that schools remain open and education continues to take place?
Yeah, so thank you to both the previous speakers. I think exactly as was echoed, we need to do the granular, the deep dive per school and per area. So policies are great, and we believe in the national policies and we implement policies. But what we find in a specific context, things are different. All things are not equal in every school setting. So, for example, I could go to a school up the road and have one set of rules by a principal or the SMT and a different one. So I think really more support for the SMTs, more support for the SGBs and the parents at the school, so that we do a deep dive per school and say, how do we support your school? What do you need? What are your stakeholders? Who do we bring alongside the school? Because a school sits in a community, and there are partners, there are churches, there are CBOs, there are people around the school setting. So if we've got an increased learner pregnancy in this school, what do we need to do to pull in stakeholders around the school community to support that school? So I'm saying we definitely support policies, but we also need to go right down to where the rubber hits the road and make a difference for our learners at that level. Thank you.
Thank you very much, Colleen, for that response. And I think in South Africa, we are fortunate because we do have a school safety framework that talks to exactly what Colleen is talking about, to say in a particular school, looking at the culture around the school, looking at the support and the resources of the school, how do we ensure that we make that school respond to their learners' needs? Colleen, second question that you can comment on is the concept of, as we continue to implement national policies, how do we ensure continuation of learning for learners that are pregnant, that they remain in school and remain learning as long as possible, vis-a-vis keeping them at home to prevent them from COVID infection? Any thoughts around that?
Yeah. So what we found just at a very practical level, we were speaking about that two areas of support that was critical. So the one side was the psychosocial support and all the needs that the participant have. The pregnancy could have come from GBV, rape, or anything else. So there's so much crises around the individual and her pregnancy, especially for our younger learners. So any support that we can offer, whether it's tailored support, especially the psychosocial, and on the other side, the flip side of that same coin is the academic support. We genuinely understand when teachers say, "I'm not the midwife. I can't help you. I can't do." So then we say, learners, if possible, and it works well with our education department, like I'm saying, what community partners are there so that we can bring homework to the girl, we can bring learning to the girl, and offer her the two things, the psychosocial component as well as the education component, and then still have her right. So yeah, thanks. Thank you so much, Jane.
Thank you very much, Colin, for that response. Colleagues, just going back to the polls, according to the results of the poll, in our question looking at from the CSTL pillars, which ones do we believe have the greatest impact on recovering the efforts to providing necessary support systems? Health education and promotion, including comprehensive sexuality education, got 25% of votes. The curriculum support, ensuring that learners are able to learn in school and outside school, got 21%, taking the second spot. Nutrition support takes the third spot with 4% of votes, and core curricular interventions and activities takes 2% of the votes. So that is how we voted in terms of the pillars. And thank you very much, colleagues, for participating in this morning session of today's conference, starting at the first presentation that was reminding us of the ESSA commitments, looking at how our political support and political commitment continues to drive the programs and interventions that we would like to implement, looking at the multi-sectoral support and multi-sectoral response of our commitments in terms of the different ministries, education, health, social development, and the ministry responsible for youth, but also looking at other components of the multi-sectoral response, looking at our communities, looking at our parents, looking at our donor support, and looking also at our youth themselves in driving the agenda around SRH services. Looking at how do we take the ESSA commitments to align with the SDG goals. So we've got 10 years to renew our commitments and take the agenda forward. Looking at the work that Yvonne has discussed, how COVID-19 has impacted on the health and education systems for our youth, especially access to sexual and reproductive health services, as well as in ensuring that the comprehensive sexuality education continues to be implemented, looking at the impact of the work that we are doing in an effort to digitalize CSE, how that is going to impact into our rural communities and our rural learners. The work that NACOSA has discussed today, how do we ensure that we continue to support our learners despite a pregnancy that they're experiencing, to ensure that we reduce the learner dropout rates in our schools. And we continue to ensure that care and support for teaching and learning do take place in our environments. I'm going to give you a 15-minute tea break. I'm very generous today. I'm a generous chair. I'm going to give you until 10:35 to come back, as we will be starting exactly at 10:40 with our session, with our next presentation. We've got exciting presentations, so go grab a cup of tea and rush back to your screen, and you join us as we continue the session. Thank you very much, colleagues.
Thank you all.
Thank you.
Bye-bye, Yvonne. Bye-bye, Prof.
COVID-19 is a wrecking ball of my life. We were away from school. We were not able to learn, we can't go to school. Everyone's just roaming in the streets. So in Zambia, you are no one without school. With my dad and my little sister. We don't have that cash that you can say maybe we have money, no. Me and my sister were making samosas to raise some money for her to go to school. I want my sister to go back to school first because the guys now they have that time to go smoke weed wherever they are, drink alcohol, make noise, violence everywhere. And for girls, the main reason is teenage pregnancies. I'm kind of scared maybe I won't go back to school. So I started raising my own money. So I go to the workshop with my dad because I wanted to make just a difference in the family. Others never went to school, but I have that chance. What I want to be is an electric engineer. I want to be like someone in the future. I want to make a legacy.
Is he in the room? Good morning again, ladies and gentlemen, participating in day 2 of the CSTL conference. We are now on part 2 of day 2 of this conference. I exercise my power as a chair, and I gave you half of the results of the polling, with CSE and health education being number 1 at 22%. With curriculum support at 20%, nutrition support at 3%, and co-curricular support at 3%. But I did not tell you that psychosocial support was 51%. I wanted to keep that as a surprise to reveal for this part 2 of this session, as we will be solely focusing on providing psychosocial support as a key intervention or as a key pillar of the CSTL framework. So my next speaker is going to introduce this topic, looking at the neuropsychological impact of COVID-19 lockdown on children and families. What is needed now? That will be Professor Maximus Sefoto, who is an associate professor for the Faculty of Education, Department of Education Psychology Manager at the University of Johannesburg. Prof started his career on career guidance and disability. He has trainings for mental health practitioner, for occupational therapists, educational psychologists, teachers and parents of learners with neurodevelopment learning needs on career transitioning on youth with disabilities for home to school into the world of work. At the university, Prof is a co-director of Developing Center of Excellence in Neurodevelopmental Learning Needs. He is also leading the collaboration with the University of Carolina, Davis in the US, and leads in the field of neurodevelopment. The central focus for his work is around autism spectrum disorder, which is still presenting a lot of challenges in the field of neuroscience, as well as impacting in our education outcomes in our schools. I'm now going to invite Prof to talk to us around what is needed, looking forward at the impact of COVID-19 lockdown on children, on families, around neuropsychological impact. Over to you, Prof. Hi, Prof, can you hear me?
I can hear you, Madam.
Thank you. Over to you, Prof. We are ready to take your presentation.
Thank you so much. Ladies and gentlemen, good morning. Dumelang, ahe. This morning, I am honored to be among you to share a little bit around the neuropsychological impact of COVID-19 lockdown on especially children and family, and what is needed to be done thereafter. May I start by saying that this is a new field that is developing, especially in our context that we refer to as the South-South context. When you look around South Africa, you realize that there are remnants of neuroscience and neuropsychology, neurodiversity, neurodevelopment that are happening around the country. We have, for example, the University of Cape Town, which is leading in this, but also at the University of Johannesburg, a center of excellence will be developing that deals with the neurodevelopmental learning needs for our children. Now, neurodiversity, controversially, is supposed not to be seen as the same thing as disability. Some people say, well, it's disability. Others are saying, no, it's not disability. But I guess that's why we have the thing called paradigm, because a paradigm is one's worldview, is how you view things, how you look at things and interpret them for yourself. But in this presentation, I would like us to link with the idea that neurodiversity is not necessarily supposed to be seen as disability, because Tim Goldstein, who is a neurodiverse communication specialist, says that the concept of neurodiversity is about people who think different, or just being different thinkers, not being broken human beings. I want to believe that in many societies, anything that has to do with illness is looked at from a negative perspective. Anything that has to do with difference, disability, and neurodiversity is looked at from the perspective of a human being being broken. And within the space of families and children, we really want to demystify that and look at this as part of humanity and as part of what we need to deal with in a way that brings about the positivity that a human being is known for. And therefore, we look at the types of neurodivergence, neurodiversity as it were. These are all the types that when we deal, I remember that, in one of the courses that we look at the university, at the course that deals with remediation, we touch upon many of these. And in fact, looking at them, we realize that most of the time, it is us in the education sector who need to understand more the meanings of these so that we can help families, we can help our learners to understand themselves better. Surprisingly, autism is the first one on the list. And I know that as the country, we are very much interested in getting to learn more and more about issues of autism. As it is called the autism spectrum disorder. And the importance of neurodiversity, therefore, is to look at the fact that you might be sitting in a home with either a parent who has one of this, or maybe a child who has one of this. And any family member can experience some of this. And we know that when COVID-19 started, it actually caught us all unawares, unprepared. So what I'm going to be sharing with you this morning is nothing of a panacea, but it is a way of saying, let's look at 1, 2, 3, so that at least we can respond effectively in terms of what then needs to happen from then on. So the neuropsychological impact of COVID-19 during lockdown. The important thing here is the neuropsychological. What are we trying to look at? That COVID-19 lockdown affected us or impacted us neuropsychologically. What is neuropsychology? Let's start from here, our own experiences. When we all found ourselves now locked down in our houses, everything is strange. We are now 2 or 3 or few family members in the house. We don't know what is going on next door. We look at the television, everything seemed to be so dark, so inexplicable, so uncertain, so unknown. And we began to feel a lot of fear. We began to feel a lot of discomfort, a lot of, claustrophobic, feelings that you would not even want to step outside your door because of the fear of this thing that is supposed to be in the air. So the neuropsychology is saying to us, we now need to find out what happens in our brains that eventually impacts on our behavior, and how does that behavior affect us at the end of the day. So neuropsychology, as I said, is a branch of psychology which is a discipline that focuses on the complex relationship between the brain and behavior. We know that psychology generally deals with, behavior, but now neuro comes in and injects a lot of, understanding of how the brain operates so that it leads to the result, which is behavior. So neuropsychology, therefore, aims at understanding the relationship between the brain on the one hand and the mind and behavior control on the other. These are three things that, ladies and gentlemen, are very complex. Complex in a sense that, yes, for millennia, philosophers started pondering around issues of the mind. What is the mind? Even now, it is still very difficult. As I said earlier, we are dealing with a complex field. But if we were to ask a mundane, ordinary question, but which becomes pertinent today, what is the mind? It is a mind-boggling question, but we realize that neuropsychology is now beginning to make inroads in terms of trying to understand our mind and how it controls behavior. Now, everything starts with the brain. There we can say that neuroscience has made a lot of impact. There have been a lot of researches, that have been developed. And for now, we think we understand, we can talk of the left brain, the right brain, and the impact of how that speaks to the behavior at the end of the day. But unfortunately, COVID-19 came and impacted. It really destroyed our neuropsychological makeup because our minds became so confused. We are now confined to this space. We are surrounded with fear. We are in confined space. We don't know where the next meal is going, or whether it's safe to even go out there and buy food, whether it is correct to take our children to school, and let alone children with neurodevelopmental learning needs. What of them? If a lot of us were who we could ordinarily call ourselves healthy, and then all of a sudden we are caught up in this COVID-19. A study by Solomon and Cohen said that according to the social isolation sector of our life, people were claiming that in the whole period, they would meet maybe one or two or three people, or even lesser. And some people were crying the fact that they were not meeting with their parents, staying at home all the time. But interestingly, anxiety levels were heightened, as we can see, that here it says increased anxiety, so that it really would infect behavior change in the future. And then we are concerned with what is going to happen long term. We could see that it says here, normal anxiety, high isolation, because of high isolation, increased anxiety because of her. These are the things that were happening to us as we were sitting at home. But we look again at the impact of the pandemic on one of neurodevelopmental aspects, which is autism. This study said that significant deterioration in mental health with causes of most negative impact being that there was uncertainty over what will happen next. We were sitting in our own houses, not knowing, what next to expect. And the disruption of normal routine was just unbearable. But this is the reality that we were facing. And another study corroborated this, if we can look far down, uncertainty over what will happen next and all that. But we can see that in the red, it says these were now seriously negative aspects of what was happening. And the fact that at the end of the day, we were faced with a lot of problems that we did not expect. And in the middle here, it speaks again of reduced support. Systems were clogged. Everything was happening and everyone was confused and we didn't know what was happening. This is a study that was conducted here in South Africa. And again, as we go on, we look at now what is needed. And by way of just sharing a few things from the literature that I gleaned, is that we need to make certain that the spread of the coronavirus is contained. This, ladies and gentlemen, is not going to be the responsibility of governments or departments. It is going to be the responsibility of all of us. We are all responsible for containing this. Yes, let the systems be in place, but at the end of the day, it is what we will do. So again, online counseling services. I know that we may not be very strong as a country in this, but this is what is being encouraged by our own people here who are saying we need to do this. If people will feel that they are now confined in their space, we are now being told that wave 4 is coming and we will probably be locked down again in our houses. And there's so much frustration. And the question is, can counseling services be provided online to support families and children? And then mental health first aid. This is very interesting because now we know first aid as something else, but now the colleagues are suggesting that we look at mental health first aid, where people now, even those who are not necessarily providing counseling services, but they can provide first aid in terms of mental health, to take care of those little bits and pieces that encourage us to say that let's keep on fighting so that we behave in ways that while our minds are overwhelmed, while our brains are processing this unknown phenomenon, we are at least having support that will take us out there. Also, mobile outreach programs are being suggested so that people who do not have the opportunity of online should be reached out, because we cannot forget that there are a lot of our people who don't have access to online systems, but they need also to be supported. And ladies and gentlemen, if hunger can be addressed, this will go a long way, because a lot of people are hungry, they don't know what to do in their homes. And I want to end with a quote from Vivian Green, who says that life isn't about waiting for the storm to pass, it's about learning how to dance in the rain. So we need to learn to dance with the COVID-19 and get out of it surviving and letting our people more and more getting cured, more and more getting vaccinated, so that we will say at least we have done what needs to be done. Ladies and gentlemen, thank you very much. This is the end of my presentation.
Thank you very much, Prof, for your presentation. And colleagues, as we had agreed, you'll post any questions on the chat box, and also if there are any chats you would like to undertake, our chat box is available. Colleagues, let me take you to the next presentation by Dr. Deva Govender, who is a teacher by profession. He was a maths and science teacher, and then a deputy principal. He has held numerous senior management positions in the Gauteng and Limpopo Department of Education, as well as the National Department of Basic Education. He has served as program manager for a couple of large-scale programs, including a program that was looking at district improvement for the education sector. Dr. Govender currently is a program manager, a National Education Program Manager for the NECT, that is the National Education Collaborative Trust, which is a body that supports DBE in facilitating and ensuring multisectoral work around responding to the education needs. Dr. Gavender's topic today is going to be talking to us around lessons learned from piloting community-based psychosocial support interventions during COVID-19 lockdown. Over to you, Dr. Gavender.
Thank you very much, Chairperson. Good morning, ladies and gentlemen, friends and comrades. There's about 350 of you on the platform. It's great to speak to you. The starting point, I think, that would be very useful is to look at some statistics on infection rates. So before I do that, let me just give you an overview of this short presentation. I want to talk about the connection between the infections, hospitalization, and deaths, which results in trauma, and that in turn affects teaching and learning. Then I want to speak very briefly on the two-pronged COVID response, and then share with you the findings of the community-based psychosocial support interventions and conclude with some key lessons. So you will see a graph that on the vertical axis has the number of infections running at, actually that it's 7-day average infections. And in the graph, you will see the 3 waves that the country went through. And at the height of the pandemic, the infection rate was between 15 and 20,000 per 7 days. So the key point that I want to make is that as the infection rate increases, there is an equivalent increase in the anxiety and trauma experienced by the population, particularly in the affected homes. So if that is the case, then we are going to see in our classrooms where kids come from affected homes that children and teachers may have troubled minds, and that in turn is a barrier to teaching and learning. So if we look at the presentations that were made yesterday and even today, 2 clear points come through. And the one is that there is a high demand for care and support, specifically in relation to psychosocial support. And secondly, the level of provisioning to respond to that demand does not match that demand. So I think the work that was done in the NECT with the DBE and NGOs is going to help in increasing the supply or provisioning of psychosocial support. So let me go to the points that relate to the collaboration between the NECT and the DBE. Right at the beginning, when the first lockdown was announced, research was undertaken on how education systems cope with disasters. And we looked at 4 countries, and those findings were very, very useful. And I'm just going to summarize, because that was in April 2020. So the 4 points that came through from that metacognitive study is that 1, there's going to be a sharp increase in the need for psychosocial support. 2, there'll be increased dropout of learners and a decrease in learner attendance. And of course, increased teenage pregnancies And clearly, governments had to come up with a rapid response for education recovery in that period. The initial response to psychosocial distress targeted learners in the classroom, and subsequently at around August 2020, the need for psychosocial support for community members was identified. And I want to note the guidance that was given by the late Mr. Temba Kojana, that we should look at helping communities deal with psychosocial support. And this called for a two-pronged solution, which was advised by Godwin Khosa from the NECT. On the screen, you will see two important resources that are being used right now. A guide for basic psychosocial skills for community members. Very, very simple adaptation of the World Health Organization Responders Guide. And there's a guide for teachers and districts and school managers to use in supporting learners at the classroom level. So these are the two resources that's being used extensively in providing psychosocial support. And you can find these guides on the NECT website. Let me now move to the model for the community care and support. You will see there are 4 elements. Right at the center, we have community care and support, especially in psychosocial support. And in those bubbles around, you'll see firstly the ward psychosocial support committee, a radio campaign, social media, and telephone surveys, which when taken together will give you an integrated and a more comprehensive support for community members. That's the model. And I'm going to now move on to the first bubble, and that is the psychosocial support committee at ward level. So that committee uses the responders guide that I referred to earlier. And the trial, the pilot that was conducted was done in the Eastern Cape, Limpopo, Northwest, and Mpumalanga. And in the period of the piloting, 84 ward level psychosocial support committees were set up, and almost 2,000 community leaders were trained on the use of that guide to serve as responders. So there are 6 short modules there. In addition, at the community level, the NECT and provinces have set up what we call district steering committees. And the program to support communities was also shared with those 7 of the 20 district steering committees, where over 100 members were orientated on this program. Now, one of the challenges of introducing a program is to scale it up. So this program is in the process of being scaled up with NGOs who work in this space and with unions. So I just want to give you an idea of that initial scale-up effort. The trial was also implemented by 5 NGOs in the provinces of Gauteng, Limpopo, Western Cape, Mpumalanga, and Free State. And the model is the same: use of the responders guide, training over 2 days, and then follow-up support to cascade the use of that model on the ground. So 50 master trainers were trained in the program, And those 5 NGOs have trained a further 165 people and 200 schools. That's the one element of scaling up. The South African Democratic Teachers Union was eager to work with the NECT and the DBE to train a cohort of 120 union leaders, largely from the head office of SATU and the regional offices. So at this point, 120 of them were trained, and the union is in the process of cascading those skills to their regional structures, and this hopefully will reach around 66% of the teachers in the country. So the program is now moving on to the second phase, where the test will be in an entire education district. And obviously there will be a need for a monitoring and evaluation intervention. Just some statistics on the outputs. Well, we spoke about a two-pronged approach. So the first prong is involves the district and schools, and here we are looking at almost 2,000 circuit managers, principals, and school managers who were brought onto the program so that they can apply the learnings at school level to support learners with psychosocial issues. With the work that the community members are doing, there are 3 actually support or complementary interventions. The one is the phone survey, and this is very useful in getting real-time data on the status of the mental health, the fear, anxiety, concerns, and so on of parents, learners, and teachers. And beyond that, the radio campaign was used to raise awareness about the implications of the COVID prevention and care and support. And of course, with it goes the social media messages, which was sent to almost 55,000 people. And you may want to read those messages. They are on the NECT website. So, Chairperson, ladies and gentlemen, let me reflect on this program. The first point that we are observing is that the drivers at the ward level are largely the ward councillors. And in the provinces of Northwest and Mpumalanga and the Eastern Cape, we find consistent leadership by ward councillors. The second observation is that it is different, for example, in Limpopo, where the program is primarily led by circuit managers with the ward councillors. And the membership of that psychosocial committee is made up of religious leaders, traditional leaders, union leaders, and the QLTC officials from the department, the Quality Learning and Teaching Campaign officials. What we notice is that the community responders are more active when the infections increase. So we need to gradually build the capacity of community leaders to respond whenever the infections rise. And the way things are going, we don't know what the future holds for us. So if there is a fourth wave, obviously the role of the community responders will become important. There's some lessons that I want to share. The first is that going forward, we should plan to strengthen systems to respond to learner, teacher, and community distress. And that planning should fall into the categories mentioned by Godwin Kosa yesterday. He spoke about rebooting, recovery, and building back better, which means the planning to strengthen systems to to provide care and support has to be for the short term, intermediate term, and the longer term. The second lesson is that community leaders have an important role to play in supporting community members. How? One, to use the social capital that resides in community leaders as responders to the emotional stresses that one would find in the communities. Secondly, to support the return of learners who dropped out of school and to support households with food parcels. And the third lesson that we take from community leaders is that we have to pool our collective social capital. Government departments, NGOs, unions, people working in the CSTL space, as well as those community leaders. So the NECT has created what we call an investment portfolio for interested organizations and individuals to contribute their expertise in support of the DBE to respond at classroom level and community level. Thank you very much, Chairperson. Thank you very much, ladies and gentlemen.
Thank you very much, Dr. Govender, for that wonderful presentation. Colleagues, as indicated, we are still chatting on the chat box, and we are posting our questions on the question and answer part of our screens. We will take questions after this session. As we continue with our last presentation for the second part of day 2 of our conference, we are looking at how do we ensure education recovery after COVID-19. We had the first presentation, we had the second presentation. We are now taking a third presentation that is going to look at the value and the benefit of psychosocial support task sharing during COVID-19, a case for child and youth care workers. This presentation is going to be given to us by Dr. Zeni Tumbudu. She is the Deputy Director at National Association of Child and Health and Care of Child Care Workers, NACCW in short. Dr. Zeni serves as a chairperson of the Professional Board for Child and Youth Care Workers in South Africa under the South African Social Services Practitioners Body. She has a PhD in child and youth care work, and she also has more than 40 years of experience in the sector. Dr. Zeni, I wanted to say 20 years so that I don't give out your age. She spearheaded advocacy campaigns linked to the statutory recognition of child and youth care field and developing national standards for the training of child and youth care workers in South Africa. I'm going to hand over to you, to Dr. Zeni, to give us your presentation. Thanks.
Thank you. Just give me a minute to share. Sure. Thank you very much. And thank you very much for the opportunity to present on the value and benefit of psychosocial support task sharing during COVID-19, a case for child and youth care workers. If I could just start by saying that the National Association for Child Care Workers was established in 1975 as a membership-based professional association and a membership-owned non-profit organization. We are the only professional association in South Africa, and of our many strategic goals and areas of operation, one of them is the development and replication of models. And this presentation demonstrates the work that we've done with the Izibindi Izikoleni model, which is developing and identifying and demonstrating the role of child and youth care workers in school settings. Child and youth care workers are one of the 2 social service professions that are statutorily regulated with the South African Council for Social Service Professions. Child and youth care workers are regulated by the Professional Board for Child and Youth Care Work, which is responsible for the registration, education and accredited training, professional conduct and ethical behavior, ensuring continuous professional development, and fostering compliance with professional standards. So the scope of practice of child and youth care work allows services to children and youth in a range of different settings, including residential care, which are child and youth care centers and secure care centers, community-based programs, including family work, health and education settings such as schools, and of course, an opportunity to work as well in inclusive schools, in farm schools and hostels, special schools and resource schools. Child and youth care workers provide prevention and early intervention services, as well as child protection services to children, youth, and their families. So what is child and youth care work? Child and youth care work is direct work with children and youth in the context of their families and communities, and in the context of schools within the school community. Child and youth care workers promote the social competence and healing and development of children and youth by participating in and using the everyday environments and life experiences, and through the development of therapeutic relationships with children. Relational work is actually the heart of child and youth care practice. So the hallmark of child and youth care practice includes child and youth care workers engaging with children, youth, and families and communities in collaborative and respectful ways. They take practical action to create conditions for young people to experience meaning, worth, and connection. They support children and youth to imagine hopeful futures for themselves. And they bring themselves fully into the therapeutic relationship with children, youth, and families. So children, youth, and families experience the presence of the child and youth care worker, the adult, in their lives. 3 central concepts to understanding child and youth care work is, like I said before, it is relational practice. We're talking about relational work being a way of being with children and youth within their life experiences, bringing ourselves into the moment in order to create moments of connection, moments of discovery, and moments of empowerment with ourselves and each other. It's all about connection. And child and youth care workers engage in a life space work. Our methodology of work is life space work, which is a way of conceptualizing work with young people and their families in spaces where their lives, where their lives unfold. And we talk about life space work as not just the physical life space, which might be in the education sector, the school environment, but also the emotional spaces of children, the social spaces of children where they might be being bullied, the intellectual or academic spaces of children, like with the progress learner who's struggling to read. And of course, in the virtual life spaces of children, where we had the opportunity in COVID to demonstrate the role of child and youth care worker in connecting with young people in the virtual life space. And one of the other central concepts in child and youth care work is the developmental and therapeutic use of ordinary daily life events. The little story and quotation I give talks about a little kid washing socks with the child care worker. They're talking about, how was your day at school? How are you getting along at school? Are you getting along with your teacher? What books are you reading? And in that way, you can discover whether a child has been bullied. My child care workers in Izibinde Zikoleni tells me that the child and youth care worker will notice during the break that a child is sitting alone and reading a book under the tree or on the bench by themselves. And the child care worker would go and join them and say, what are you reading? And other children would come in to join in. And in that way, the child and youth care worker, in a very ordinary way, brings a social network of peers and friends around the child just by their presence and just by noticing a child sitting alone. So as a regulated workforce, we have a scope of practice, which is basic and developmental care. Care is at the heart of child and youth care work. Behavior management, managing behavior like bullying and other types of behaviors experienced in schools. Program and activities, planned programs and activities for children. Developmental assessment, and just to say, we are not doing clinical assessments. We do developmental assessment and refer to clinical assessments to social workers and psychologists. We develop planned environments like safe parks and safe spaces for children to work with, and multidisciplinary teamwork, working with the education team, as well as others in the multidisciplinary team, and fundamentally always advocating for children's rights. So the Isibendi-Ezikoleni model is a model that actually is focused on prevention, early intervention, and full intervention services. We identify children and youth through referrals, through recruitment referrals from educators, and the SASAMs would indicate those children who are absent and not coming into school. And of course, the school-based support teams would actually identify children for our services. And we respond with whole school activities for the entire school, group activities for selected children at an early intervention level, and of course, individual work as a full intervention service for the most needy children in the school. And individual work would include home visits and family meetings and case conferencing. We're targeting children who are young mothers, pregnant learners, children who are suicidal that would require and get whole school services. And then we have group work activities, structured programs, chess clubs, book clubs, reading programs, and whole school activities that actually would be career expose or bringing in home affairs to do what they need to do around getting documents for children and birth documents and other things that are missing. That would be an example of whole school activity. So what do child and youth care workers do? The placement of trained child and youth care workers through the Isibendi-Ezikoleni model. Child and youth care workers work in teams and in partnership with educators and your SGBs and school management teams. The model was implemented, the Isibendi-Ezikoleni model, in 2016 in 177 schools. That was in Gauteng. Currently, we are in 70 schools across 4 provinces. And the model provides holistic, integrated child and youth care responses to the needs of learners in the school setting. The goal would be to improve the well-being of orphaned, vulnerable, and at-risk learners, to help them realize their developmental goals in education, in health, in their development, and transition into adulthood. The child and youth care workers provide psychosocial services that are aimed at addressing issues such as school dropout, teenage pregnancy, child abuse and neglect, bullying, substance abuse, and other issues that are impacting on learners. And as I said before, the program functions at 3 levels, which is prevention, early intervention, and full intervention. Just to quickly say that presently we are present as child and youth care workers, 77 of us, in 49 schools, and we've serviced 44,407 learners. And of these learners, 3,534 have received the full intervention. And these are the children that are most needy in these schools. So what do child and youth care workers, what did we do during COVID-19? What are we still doing during COVID-19? At the initial lockdown levels, child and youth care workers, remember, formed part of the essential social service professions. So we were able to provide direct services at that point in time. And the child and youth care workers did provide safe face-to-face support in child protection matters and in other emergency response services. Child and youth care workers also, through the NACCW, developed the Virtual Connection Initiative, in which child care workers stayed connected to children through virtual means. And I'll tell you more about that. But as we decreased in the lockdown levels, child and youth care workers continued to provide both the emergency response as well as the prevention and early intervention services to children through a blended approach of face-to-face work as well as virtual connection work. And we've never really stopped with the virtual connection. All the pictures I've put out demonstrate child and youth care workers in the school environment, and you can see how active they are and how they're actually supporting the COVID-19 protection. So child and youth care workers have offered services such as COVID-19 screening. They provided gate duty monitoring, using this routine to connect with children Quite often when you're having your temperature checked and sanitizing your hands, the child and youth care would say, good luck with your test today. How are you? How was your morning? Wishing you well. Your hair looks very pretty today. And in different ways, connect with them to give them a good start to their day at school. They would also track attendance and dropout and make every effort to attend to them. In supporting dropouts to return to school, I know feedback where child and youth care workers did home visits, went to children and said, get to school, asked parents to encourage children to get back to school. They understood that somehow or the other, the COVID grant was encouraging people, young people to say, well, maybe that's a better option than coming back to school, and encouraging them not to go for a short-term response to their education, and playing a very active part. Child protection cases were supported, bullying, gender-based violence, young women experiencing violence from their boyfriends, family violence at home were identified and supported. Food security was a big issue, and we arranged for food parcels and food vouchers to be delivered to families, as well as working together with the school to see if there would be food after the feeding scheme that could be provided to some children to get back. Individual sessions and home visits were provided. Learner plans were developed to help them cope with the challenge of studying. Referrals were made to social service practitioners, to workers, to health workers, to psychologists, and of course, support to pregnant learners and teenage mothers and fathers as well. We assisted with tertiary and bursary applications actively in the time, as well as provided, as I said, whole group school and class activities for learners. And we played an active role in matric support. And the pictures again demonstrate some of the work that we've done during COVID time. A little bit more about virtual life space work. Child and youth care workers engaged with children and their families through WhatsApp groups, through texts, through phone calls, on a one-to-one basis, as well as on a group basis. We shared COVID-19 information and education. There was daily safety and child protection check-in calls and messages, individually and family calls. We've heard that child and youth families would take the cell phone and put it in the lounge, in the central place, on the dining room table, and the family would gather around it as the child and youth care workers would talk to them about COVID-19 and child protection issues. A study program and educational support was provided virtually. What was amazing was that with the matrics as well, past exam papers were provided. Children were working on WhatsApps with their studying, and in many cases, the childcare workers organized the matriculants, and in many cases, educators came on board to actually guide with the educational program, and the program demonstrated the support and the partnership between educators and child and youth care workers. We also did basic things like discussions on life skills and social issues. There were career expos where large numbers of children and youth were brought into career expos together, even from around the country, not just only in one province. There were reading activities that took place. The Funza reading app, Nali Bali, reading for meaning programs, and other activities, not in all groups, but things like debates, where they had debates on topical issues, spelling bees, poetry and creative writing, and even online chess. Some young people were encouraged to engage in at this time. And that basket of service that we provided expanded as the childcare workers became more confident and creative around virtual life space work. So just an example of how we worked, particularly in KwaZulu-Natal, these statistics are more applicable to them. We had more than 2,000 children and youth that have been reached through the Virtual Connection program. Close to 20,000 phone calls were made to children and youth during this time. Over 200 virtual chat groups were created with more than 1,500 children and youth. And close to 10,000 virtual chat group sessions were done, reaching these children monthly. And the pictures show moments of children and youth engaging in virtual work on their phones and of course on the laptops with the child and youth care workers and their mentors. Just to say that the Izibindi-Izikoleni model is aligned to the district development model. And the last bullet might be useful to note that child and youth care workers reside in the same communities in which they work. So they conduct home visits and arrange interventions in local spaces, be it safe parks and community venues, which means it's also a cost-effective model because they know their community and they can walk and provide home visits in most cases. They also refer children and families for various social, health, and educational services that are localized. And of course, become part of the multidisciplinary team, bringing people together. Just to say as well that in KwaZulu-Natal, in partnership with the Provincial Department of Education, learner support agents have been trained as child and youth care workers, which in a way is aligned to the same approach of district level development of psychosocial support for learners. These pictures just show you how educational support using past exam papers as a reference in a WhatsApp group. This young girl in 2000 was a matriculant. She's a young mother who was dropping out of school because she had to care for her child. The child and youth care worker was able to support her to remain in school and complete her matric, providing her with a support group with other young mothers, providing her with past exam papers, providing her with a solar lamp and chargers so that she could keep connected. She passed, by the way, her matric. She did a course in administration and is now volunteering in a drop-in center while she's looking for a job. The other picture shows learners engaging in Nali Bali reading activities on their Mobi app. Of course, teaching good hygiene practices and safety precautions. You can see creative ways of making masks, and also the tippy taps, teaching them how to keep clean even at home and sanitize. These pictures here are life space work in schools. You can see childcare workers screening learners upon entry in school, enforcing hand washing routines in school, and also assisting to sanitize common spaces in schools, playing a very active and very practical, concrete contribution to safety in schools. Some more pictures showing playing a role in social distancing during an assembly in the top picture. In the lower one, childcare workers facilitating an HIV/AIDS prevention program, but of course the distancing and the masks in place. Learners sanitizing as they enter schools, and childcare workers putting up posters in schools, educational posters about COVID-19. Other face-to-face interactions, as I said, food parcels were secured and distributed to families. We had a partner in the Netherlands who provided us with solar chargers to matric learners, and they were provided with them to assist them study in the rural areas that we were servicing. We had some donations of sanitary towels that were distributed to young girls as well. This is just a picture demonstrating how the solar chargers were used with their little lamplight, and how children around the country, if I can say, studying with the support of these lamps and chargers around the country, even as we speak. Matriculants now are using them. And just a little story on a WhatsApp group in KwaZulu-Natal, a childcare worker received a message from a young person who was 17 years old saying he's no longer going to be part of the group. The childcare worker was worried about his sudden withdrawal and called on him and said, well, what has happened? He said he had just ingested insect poison as was wanting to commit suicide. The childcare worker immediately contacted the caregiver, which was his foster parent, his aunt. He was taken to the hospital where he received medical attention. The childcare worker stayed with him and arranged for the hospital social worker to provide further services, contacted Lifeline for further support for the young person and his caregiver. The attempted suicide was a result of a fight he had with another family member. He wasn't able to cope with the situation. It was COVID time. They were all locked in the same home environment and things were quite tense. But his life was saved because the childcare worker noticed a problem that came on a WhatsApp call. She followed up on it. And after identifying his statement as a call for help, and that's what child and youth care workers are good at. They're good at actually listening beyond what people are saying awe with what people are saying and actually doing the necessary follow-up. The childcare worker continues to work closely with him. He did actually return to school. He passed and moved on to the next grade. He's part of the group activities with the childcare worker as we speak, and he's one of the enrolled children that is receiving ongoing services. And we have just many stories of this kind of response from child and youth care workers within the school environment. The NACCW and the child and youth care sector are very grateful for the opportunity we have in our memorandum of understanding with the Department of Basic Education to promote the role of child and youth care workers in schools. And we are grateful that the Izibendi Izikoleni initiative is a well understood and respected initiative. Thank you.
Presentation. We are always excited to hear innovative approaches to support the multi-sectoral delivery of the CSTL programming. As you heard in this presentation, the NACCW is working with other critical bodies in the country to create a pool of support that will be sharing on the task of providing psychosocial support for our children in the schools. Professor has spoken to us earlier on, and Dr. Govender, on the impact of COVID-19 on both teachers and learners in our schools, how isolation and anxiety and trauma is impacting on teaching and learning, how we should ensure that we continue to prioritize mental health, especially psychosocial support for both our learners and teachers, as well as how do we ensure, as we continue to strengthen our CSTL programming in our schools, how do we ensure that we continue to create spaces for neurodiversity. Before I let you go for today, we've got a couple of questions that I would request my panel members to take and respond to. The first question is, how should the learners who have given birth be supported in case of taking care of their babies as they return back to school, especially those that are from child-headed families? The other question is, the community responders approach seems to make sense as it is a bottom-up approach. How does it relate to the proposition of having social workers in schools as well as learner support agents that are currently working in our schools? There's a question that is specific to Dr. Govender. How do the national helpline desks like the South African Child Line play a role in providing PSS interventions? I think those are the questions that I have in the meantime. I'm going to ask Dr. Govender to start responding. One is, I think two questions are specific to your presentation. One is talking about the helplines, what role are they adding in the PSS provision? And then the second one is talking about the role of school social workers as well as learner support agents within the framework of the community responders approach that you presented on. Zeni, you would also add on those responses with the work that the child and youth care workers are doing. How do they align with the helplines that are available? Also the role of school social workers, learner support agents, as well as child youth care workers. How do we ensure collaboration to provide comprehensive support? And then Zeni, I think also you might be able to tackle the question of how do we support learners who have fallen pregnant and wanting to go back to schools, coming from child-headed households. How do we ensure that we provide them with support to take care of their children? It's Dr. Govender.
Thank you very much, Chair, and thanks for the questions. As I mentioned, the two programs that the NACT has been piloting with the DBE and provinces, one focuses on the classroom, which means the moment you speak about the classroom, you got to include the role of the school managers as well as the district. And in the other, it's about a multi-stakeholder collaboration that brings community leaders together. So in relation to the first approach, clearly, if learners are identified with psychosocial challenges, then there is a referral process. So from the evidence that we have, the majority of the issues are resolved at either classroom level or school level. However, in the instance of specialized responses, the school refers that a case to the district-based support team, and it's at that level where the social workers come in. But also at the school level, the learner support agents are active in assisting with the resolution of those problems. So the second question, Chair, is very is an eye-opener for the community level structure. So you can imagine in a village where you have the structure of the pastor and the traditional leader and the circuit manager or union leaders. So we haven't looked at this option of using helplines. So I think this question actually teaches us a lesson that we need to provide a directory of resources, which would include helplines to each of these community level structures, so that they can engage the necessary organizations for help. Thank you.
Thank you very much, Dr. Govender. Before you respond, Dr. Zeni, may I request my conference participants that we've got the second batch of a question around the polls. So can we please go back to our polls on the platform? You click on polls. There's a question for you there to vote. Which of the services or interventions to be included do you believe can mostly impact on teachers and learners' mental health and overall wellness? We've got options to vote for: psychosocial support, social workers, increased and easier access to educational psychologists, increased training of school teachers, school-based support teams, and leadership to provide support to learners, digital and technological mental health and wellness interventions for easier and immediate access. So colleagues, if you can start voting, we will look at the results of the votes after Dr. Zeni's response. Over to you, Dr. Zeni.
Yes, I just want to respond to your last point there to say that it seems like you've forgotten to include child and youth care workers as something to vote on, because we believe that the direct role of child and youth care workers in schools would be an excellent support for psychosocial support in schools. I want to say that just to follow up on the previous response as well, just to say that child and youth care workers network resources to children and youth and learners and families. And we're very good at doing that in identifying what are the resources that are available, be it Childline and promoting Childline's numbers and Lifeline's numbers so that they can access the services of counselors, but also networking them into the local clinic, the local nurse, introducing them so that they feel comfortable to use community resources. So just in response to the networking of resources, a very critical role is to create access. In response to the question about the child-headed household, it's obviously a youth-headed household where the learner is pregnant would need to be at school. What the child and youth care workers would do is support, first of all, the learner to remain in school by taking a shared a responsibility around how do we actually care for the baby, to make sure that the child is cared for with neighborhood support, with family support that is brought in, and with, of course, the role of the child and youth care workers in the communities playing a role in supporting a youth-headed household. In our programs already, the child care workers tell me that they have support groups for young mothers, where they are provided with opportunity to get support for their study program, and at the same time additional support and to care with the responsibilities of being young mothers. And I think it's been an example of one of the successes we've had in the Izibindi Izikoleni program, where child and youth care workers as direct practitioners have responded. I think you asked the question as well is how would we work with social workers and also school psychologists? I think through referrals. Once we identify children in schools that we pick up in the work that we're doing, which is gate duty or supervision of and support during lunch breaks and tea breaks. And sometimes we hang around the toilets where smoking and other issues take place so that we can pick up needy children. And then we would identify them. And if we feel the problem obviously requires clinical assessment and requires the role of a social worker, we would refer, because it's logical that the social worker is not going to be quite in the spaces child and youth care workers are. But if we identify those children that require support, we would refer to them and follow up on referrals to make sure that services are received. Thank you.
Thank you very much, Dr. Zeni, for those responses. Results for the poll. Okay, I'm not seeing the results for the poll, but ladies and gentlemen, as we going towards ending today's session, thank you very much for participating in this session. This is a very important pillar of our framework on caring and support for teaching and learning within the Department of Basic Education. One of the key issues that this framework is teaching us and telling us within the education sector is that a school exists within a community. And if we would want to make sure that our schools are safe and our schools are effective in providing teaching and learning, we have to collaborate with the different role players in the community to ensure that our learners remain safe and are able to continue being taken care of in our schools. The challenges that the education sector faces in dealing with learners within the classroom is a reflection of the challenges that the South African community is facing with, looking at the pandemics, HIV, unintended pregnancy, gender-based violence, now the impact of COVID that it has on our psychology as a country is reflected in the classroom. So ours as a sector is to make sure that we are strengthened, we are empowered to deliver teaching and learning within an environment that will be suitable for learning for our learners, but also be able to provide the resources that will ensure that they continue to learn, they continue to feel safe in the schools, especially when we look at issues around mental health. So I would like to thank my presenters for the second part of today's session, that we continue to drive the agenda around psychosocial support. We continue to provide different models of implementing and supporting mental health and mental health first aid for our youth in the country. Thank you very much, colleagues, for participating in today's session. We look forward to seeing you tomorrow in the last session of our conference. Tomorrow is Friday. We will be starting exactly at 9, and come and join us for more presentations and more robust conversations and discussions as we build ourselves gearing to the new academic year in 2022. We are hoping it will be post-COVID-19, but Dr. Cavender, when he was presenting here, he showed us waves of COVID-19, and there are conversations around the fourth wave of COVID-19. Therefore, as the education sector, we are hoping that by the end of this conference, we would be ready to tackle the 2022 academic year. Thank you very much for your time, and have a good afternoon.
Thanks, Doc.